If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today, we're going to cover neutropenia, including initial assessment, follow-up and management, always focusing on what is relevant in primary care only. I have based this episode on Haematological guidance by Camden CCG, Manchester Foundation Trust and King's Health Partners. The links to them are in the episode description. Right, let's jump into it. Neutrophils are the most numerous subtype of white blood cells, and they are the body's first responders to bacterial infections. Neutropenia is when the neutrophil count is low. A normal neutrophil count in adults ranges from 2 to 7.5. However, an isolated low neutrophil count is extremely common in clinical practice. It results between 1.5 and 2, while technically below the normal reference range, is rarely clinically significant. Many healthy people fluctuate in this borderline range due to factors such as minor viral infections, recent exercise, or simply natural day-to-day variations in blood count. We also have to remember the normal ranges differ across populations. People of Afro-Caribbean or Middle Eastern heritage often have a normal baseline neutrophil count between 1 and 1.8. This is known as constitutional or ethnic neutropenia, which is of no clinical consequence. It is a benign, lifelong finding and does not increase susceptibility to infection. For these patients, referral is usually only needed if the neutrophil count falls below 1 on repeat testing. For everybody else, and for the purpose of this episode, we will define neutropenia as a neutrophil count below 1.5. Possible causes of neutropenia are as follows. First, we have drugs such as phenytoin, carbimazole, antipsychotics and cotrimoxazole, which can suppress neutrophil production in the bone marrow or trigger immune-mediated neutrophil destruction. Some drugs are directly toxic to the bone marrow, while others induce antibody formation against neutrophils. Then we have malignancy, including conditions like myeloma or any cancer that infiltrates the bone marrow. This reduces the bone marrow's ability to produce neutrophils. Additionally, chemotherapy and radiotherapy further compound this by damaging rapidly dividing cells, leading to predictable and sometimes profound neutropenia. Also, vitamin B12 and folate deficiency, which impair DNA synthesis. Because neutrophils and their precursors divide rapidly, they are particularly sensitive to this. Then we have iron deficiency, which reduces the efficiency of hematopoiesis in general. Although iron deficiency is normally associated with anemia, iron is also required for normal development of all blood cells, including neutrophils. Severe or prolonged deficiency can therefore lead to malneutropenia. Another cause can be autoimmune diseases, which can cause neutropenia through immune-mediated destruction by autoantibodies that target neutrophils or their precursors. Then we have viral infections, including Epstein-Barr virus, HIV, and hepatitis B and C, which can directly suppress bone marrow activity or cause redistribution of neutrophils from the bloodstream into tissues. Many other viruses also transiently inhibit neutrophil production during acute illness, making mild neutropenia very common. Also, another possible cause is excess alcohol, which is toxic to the bone marrow and can impair the proliferation and differentiation of myeloid precursors. Chronic alcohol excess is also associated with nutritional deficiencies, particularly folate, compounding the effect on bone marrow function. Then we have liver disease and cirrhosis, which can lead to neutropenia through hypersplenism, causing increased sequestration and destruction of blood cells in the spleen. Another mechanism is the metabolic effect of cirrhosis on overall bone marrow function. And finally, as we have already explained, there is ethnic variation, like constitutional or ethnic neutropenia in people of Afro-Caribbean and Middle Eastern heritage. Again, this is a benign inherited pattern without any impairment in immune function. How should we manage these patients? We should send the patient to hospital as an emergency if There is any evidence of sepsis because neutropenic patients are at high risk of overwhelming infection. This means they can deteriorate rapidly, often without the typical signs of infection. Additionally, we should also send the patient to hospital as an emergency if the neutrophil count is below 1 and any one of the following factors is present. First, if the patient is on chemotherapy. This is because chemotherapy-induced neutropenia can progress quickly, and these patients are at particularly high risk. In this setting, infection can become severe within hours, leading to sepsis. Also, if there is lymphadenopathy, because enlarged lymph nodes raise concern for an underlying hematological malignancy, such as lymphoma or leukemia, or for a significant viral infection causing significant bone marrow involvement. Also, if there is splenomegaly, because an enlarged spleen suggests increased sequestration and destruction of blood cells, or infiltration by malignancy or infection. Splenomegaly with neutropenia can be suggestive of serious conditions such as myeloproliferative disorders, autoimmune cytopenias, or advanced liver disease with hypersplenism. And finally, we should also send the patient to hospital as an emergency if the neutrophil count is below 1, if there are other cytopenias. For example, if anemia or thrombocytopenia is also present, this points toward a significant bone marrow problem, which increases the risk of complications. Then we should make an urgent hematological referral on a cancer pathway if the neutrophil count is below 0.5 and the patient is otherwise well. This is because a neutrophil count this low is concerning even in the absence of symptoms. Counts below 0.5 significantly increase the risk of serious infection, and they also raise the possibility of an underlying bone marrow disorder. Conditions such as acute leukemia, myelodysplastic syndromes, or bone marrow infiltration can initially present with isolated severe neutropenia before other clinical signs appear. If the neutrophil count is above 0.5 and the patient is clinically well, we can safely take a stepwise approach. The first action is to repeat the blood test within 1 week, as many cases of mild neutropenia are transient. At the same time, and as part of the initial workup, which other investigation should we request? We should investigate the underlying cause by organizing the following tests. As already mentioned, a repeat full blood count. This is in order to confirm whether the neutropenia is sustained and to check for other full blood count abnormalities. Then a blood film, which can identify abnormal cell morphology, immature cells or blasts, suggestive of bone marrow disease. It can also help detect features consistent with infection, nutritional deficiency, or autoimmune processes. Vitamin B12 and folate, because as we said earlier, deficiency can lead to ineffective neutrophil production. Ferritin and iron studies, given that iron deficiency not only causes anemia, but can also reduce neutrophil production. An autoimmune screen, because some autoimmune conditions can cause immune-mediated destruction of neutrophils or affect bone marrow function. HIV testing, because HIV can lead to neutropenia through direct bone marrow suppression, chronic immune activation, or associated infections. In these cases, HIV treatment can reverse the neutropenia and improve overall immunity. And finally, we should also request hepatitis B and C serology, given that chronic viral hepatitis can impair bone marrow function and is also associated with splenomegaly, hypersplenism, and autoimmune cytopenias. After we have done these tests, if the patient is well and the cause of the neutropenia remains unknown, our next steps will depend on the degree and persistence of the low neutrophil count. Firstly, if the neutrophil count remains below 1, we will refer urgently to outpatient hematology. This is because even in the absence of symptoms, this level carries a meaningful risk of infection and warrants specialist assessment. If the neutrophil count is between 1 and 1.5, we will monitor the full blood count for 4 to 6 weeks. This is because many cases in this borderline range are temporary, and monitoring over several weeks helps determine whether the neutropenia is improving, stable, or worsening. Then we will refer to hematology routinely if any of the following occur. First, if the neutrophil count remains below 1.5 or below 1 in African Caribbean patients due to constitutional neutropenia. This is to rule out the possibility of a chronic underlying cause. Also, if there are other full blood count abnormalities, suggesting that more than one blood cell line may be affected, raising concern for broader bone marrow pathology. And finally, if there's a history of infections or ulcers. This is because recurrent infections, mouth ulcers, or delayed healing are clinical signs that the neutropenia may be functionally significant, even if the absolute count is only mildly reduced. These symptoms suggest impaired neutrophil activity or insufficient neutrophil reserves, and they strengthen the case for specialist review. So that is it, a review of the initial assessment and management of neutropenia. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.